Hi, today let's delve into a topic where we look beyond TSH into the T3 and T4 and the ratio of it. I'm Dr. Neeraj. In the era of highly sensitive TSH, most of us clinicians have become TSH centric, treating the thyroid like a simple thermostat, like increasing the L-toxin dose when the TSH is high and decreasing it when it's low. However, we should look beyond that to the secretory product itself, the ratio of T3 to T4. This is a physiological fingerprint that tells you how exactly the thyroid gland is working, the peripheral tissue is behaving. Now let's delve into the normal physiological baseline. Under normal conditions, the human thyroid gland is a T4 factory, producing approximately 80% of our daily T4. Conversion, in contrast to only 20% of our circulating T3 is secreted by the gland, rest entire 80% is created by the peripheral conversion of T4 to T3, usually in the liver, kidneys and the muscle, by the action of T1 and T2 deiodinases. So the normal ratio in a euthyroid is T3 to T4 would be typically less than 20:1. In hyperthyroid, this shift changes to predominantly T3, a T3 dominating shift. When the thyroid gland becomes hyperactive, particularly in Graves' disease, the physiology shifts dramatically and produces something like a T3 toxicosis. This is due to enzymatic upregulation. Increased TSH receptor stimulation antibodies upregulates the activity of T1 iodinase within the thyroid gland. And then there is a preferential production and secretion of T3. The result is that the T3-T4 ratio is always greater than 20:1. So if you see a patient with a suppressed TSH and a T3-T4 ratio more than 20:1, you are almost sure you are looking at true hyperthyroidism, either Graves or toxic multinodular goiter. Then comes the thyrotoxic leak, where the T4 is a heavy signature. Now contrast this with a thyroiditis, either subacute, silent or postpartum. In these conditions, the gland isn't working harder. It's not producing more hormones. It is simply the breaking down of the existing follicles, the thyroid stores that are in the thyroglobulin and in the colloid, which contain significantly more TF and T3. So when the follicles are destroyed, the preformed TF of T4 is dumped into the circulation. And the signature, because the excess hormone is coming from storage and not from active synthesis, the T4 raises more predominantly than T3, and the ratio is well below 20:1, something like 10:1 or 15:1. So the clinical application that if a patient presents with TSH of less than 0.01 or 0.001 and you are debating between Graves and thyroiditis, think about the ratio of T3 to T4. If the ratio is more than 20, it is Graves or multinodular goiter. If the ratio is less than 15, it is thyroiditis. Coming to non-thyroid illness or low T3 syndrome. In patients in the ICU who are severely ill, there is usually euthyroid 6 syndrome. The body attempts to conserve energy by down-regulating the metabolic rate. The shift, T1 iodinases are inhibited, T3 deiodinases are activated. This results in peripheral conversion of T4 to T3 drops, and T4 is instead shunted towards reverse T3. So the ratio is that you will see a low T3 with a normal or low normal T4 leading to an abnormally low T4-T3 ratio, T3-T4 ratio. So this is how you can interpret beyond looking at the TSH, seeing the FT4, FT3 values or T3, T4 values. Actually, FT3, FT4 would be more useful because that would bypass the abnormalities created by the binding globulins. So looking at the ratios speak to you about the underlying etiology rather than just looking at the TSH and saying he is hyperthyroid or hypothyroid. So the final takeaway is the ratio in your biochemical compass when the TSH is suppressed. The ratio tells you if the glands are building up, high ratio, or breaking down, low ratio, or if the patient is taking their hormone orally, hypersupplementation. So in that also there will be low ratio.